Hi everyone. I'm Dr. Malijan, Greco Malijan. I'm an internal medicine specialist in the Philippines, and I'm currently studying international medicine. International health and tropical medicine here in Oxford. And I signed up for this topic to share with you because this is something that I think is very relevant in daily clinical practice, and it's something that we do a lot in practicing evidence-based medicine. And I hope that although this is quite short and very rather brisk run through the topics of survival analysis, I hope you get some appreciation from it and also be able to apply it in daily life and in reading all those journals that and all those new literature that we have. So I'll structure it in the following phases. So our learning objectives are as follows. So I'll talk you through the concepts of hazards, censorship, and survivorship, and censoring and survivorship. And those are essential because to be able to appraise Kaplan Meier curves, we need to understand censoring and survivorship, and Cox regression analysis really depends on hazards. I will give time in between the big chunks of this lecture to for questions, but also I want this to be interactive, so I'm gonna put out some polls. I've given a few questions from the as a pre-session quiz, and it doesn't matter if you take that. I hope that by the end of it, we'll be able to answer it together. And I also want us to look into the assumptions of survival analysis and how to test that. All right. So I'll fire up. So just as a review, I know you guys have had sessions on linear regression and logistic regression. Linear regression, as you can remember, looks into or assesses those using continuous outcomes. So how does glomerular filtration rate as changes as predicted by whichever variables? What are the predictors for blood volume? So these are continuous outcomes. And then logistic regression, the simplest form of logistic regression is looking into binary outcomes, whether or not the patient died, whether or not the patient is readmitted. So it's like a positive or negative outcome. And I'm not sure if you've been through Poisson regression, but this is another type of analysis that looks into count data. Count meaning how many events are happening as a function of or with the component of time. So number of deliveries in a day in ward A, it's something like that. Looking into rate and the element of time, but it can also be related to space, such as the number of malaria parasites in a smear. But what's important is so far in these types of analysis, the assumption is that the rate at which events occur is constant. So meaning you have the same rate throughout this analysis. And there are instances when that rate isn't really, when that assumption cannot be applied. And for instance, let's look at some examples. So it's not always constant. For instance, the rate of mortality among women with breast cancer. I want you guys to focus on the middle graph here, showing how from the time of diagnosis of breast cancer, this is the mortality rate of women who die from breast cancer. It seems that mortality from breast cancer peaks at around 2 years and then it goes down. So that rate of mortality changes throughout time. So remember how we use the concept of time here. In essence, we're looking at rates as well. And then here, so this is a risk of death since total hip replacement for osteoarthritis. So after surgery, the rate or the risk of death is high and then it eventually goes down in this study. And this one, so this is looking at readmission, all cause readmission rate for patients admitted for heart failure. So meaning these patients were admitted for heart failure and then within 10 days they had the highest risk of being readmitted. And then that kind of rate decreases as you go further away from that day of discharge. So we have to find a way of factoring in rates and how can we better understand and explain them. And that's what survival analysis is about. But before we go further, let's look at two functions that are essential in looking into and describing phenomena with varying rates. So first we have hazard function. It's important to note here it has a small h, small ht, and it refers to the instantaneous rate of an event occurring at time t. We will describe this further in a bit. So instantaneous rate at any point in time, this is at time t. This is that rate that of an event occurring. And then survival function here is the probability that an individual will survive up to and including time t. So they're quite describing similar events, but in different ways and in different mathematical statistical terms. I think it's best to illustrate it in this manner. Okay, so don't focus on this, focus on the graphs first. So we are looking at instantaneous hazard and survival estimates for parasitic recurrence among less than 5. Just essentially look at the color of the graphs, the curves. So if we see here different, these are models, so they're predicting different types of behaviors, but they look into the hazard function and the survival function. So it seems that for the hazard function, when it increases, it seems that survival decreases, right? And there are more nuanced way of interpreting that. But for our purposes, I think, and for your purposes, I think it's important at the very least to understand this kind of relationship. Actually, the formula, and we haven't talked about this yet, but hazard, that small ht, the instantaneous hazard function is this one. But we have concepts such as cumulative hazard. When you add all those rates through time, it becomes big H, and that's the sum of all the instantaneous rates. And that is related to the survival function ST. So you don't have to memorize this, you don't have to know it, but at the very least, get acquainted with this relationship and with how this looks like on the graph. Like, look at the green lines. When it increases, the survival function decreases. So again, these are trying to capture different aspects of the natural phenomena, and these are like modeling. Sorry, these are modeling projections. So so far we've talked about, in this analysis, survival analysis, we're looking at events that have different rates of occurrence, that have varying rates of occurrence. And we talked about hazard function and survival function. Any question so far? So the next concept that I want us to understand is censoring. Censoring is when participants who did not experience the event during the observation period are said to be censored, meaning they are, well, the official term is censored, but as long as patients do not experience the event during the observation period, when you conduct your study, they're considered censored. And it's important to take note of them because we don't know exactly what their survival time is, or how well, what are the odds of them surviving. We don't know we don't have any information within this subgroup of individuals or participants. So we can classify censoring. Well, there are many ways to classify it, but broadly can be classified into right and left, right versus left, and informative versus non-informative. So right censoring is when the participant remains event-free during the observation period, but can still experience the event, sorry, without a T, event in the future. So meaning they finished, somehow they got off from that observation period, and they can still experience the event. And this include those who are lost to follow up, and those who have completed the study and did not experience the event. So for instance, the event is mortality that we're looking. So those who were lost to follow up from the study, they can still die, but we don't know how long the survival time is. So that's considered right censoring. And those who completed the end of the study, so you finished 5-year observation period, by the end of it, they're still alive, so they can still experience that event. But they are right censored, meaning we don't know what happens afterwards. The other side, and less common side, is the left censoring, meaning the event somehow happened before the observation period. So patients might be diagnosed with an infection prior to the enrollment without us knowing. These are more administrative reasons why this happens, but it occurs, but rarely, but it occurs. So it happens before you start observing. The patient was somehow enrolled to your study, and apparently the event has already happened. Okay. And then second, so informative versus non-informative censoring. So informative censoring is when the probability of being censored is related to the probability of the event. What does it, well, I think an example would be when the patient is too ill to attend to follow up, to attend the follow-up session, likely it's because the patient will be lost to follow-up, likely because of negative experiences that that patient is already happening or experiencing from whatever your intervention is. It can also be that the patient already felt better. So after giving them the treatment, you're still supposed to observe them. But after giving them the treatment, the patient already improved. They wanted to travel out of wherever they were because they were already feeling better. That can be an example. And those, as you can see, the probability of being censored, them being lost to follow up or not going into the study, dropping out of the study, is related to the probability of the event, or how likely they are, or how sick they are, or how well they are. So informative censoring. As opposed to non-informative censoring, it's unrelated to the probability of event. So the probability of being censored is unrelated. Example is a patient die, your outcome is death, your event is death, but a patient die accidentally, not related to the disease that you're studying. So that is non-informative censoring. Or if the patient completes the observations period of the study, that's also non-informative censoring. So you censor them, but they ended just because the study ended. So that is called non-informative censoring. And it's important because non-informative censoring is an assumption. So when we have censoring in Kaplan Meier and Cox regression, the assumption is the probability of being censored is not related to the probability of event. That is non-informative censoring. So what I want you to get from this is the assumption of the analysis that we will be looking into closer later is non-informative censoring. Okay, and the examples are accidental deaths and end of follow-up. Those are the most common. And as for the left and right censoring, the most common is, more common still, is right. Those who are lost to follow-up and those who have completed the study. I think it's better understood using a picture. Okay, so we have patients or participants A, B, C, D up to J. And then we have the start time and an end time. So these are the observation periods. And then we can see the dashes like this, the vertical small dashes are the start and end. And then if they are event free, so let's say the event is death. So if they are event free, meaning they lived through that observation period. And if they have an event, this looks like a dot like this. Or sorry, maybe let's not choose that. An event may be infection, having this particular infection. Okay, so you can see that I think maybe I should start a poll here. We will decide now whether or not patient A is censored. Do we think that patient A is censored? And do we think that patient B is censored? And do we think patient H are censored? Let me start a poll. Do we think that participant A is censored? So remember, the patient remained event-free at the end of the observation period. And then do we think that participant B is censored? And whether or not, if participant B is censored, whether or not it's right or left censored. And then same for participant H. So it seems that the event happened before they started the observation period. So is this patient censored or not? Okay, so for participant A, it seems that you're right. So majority of you said that the patient is right censored because the patient completed the follow-up and did not experience the event. The patient still has, or the participant A still has the chance of having or experiencing that event. in the future. So that is right censored. That's correct. Participant B, do we think participant B is censored or not? It's a bit mixed here. So since participant B experienced the event during the observation period, that participant is not censored. We know what happened to participant B. The participant B experienced the event. So that participant is not censored. Okay, so when you see the black, the full dots within this observation period, so B, C, F, and J, they are not censored because we know the events. We know that this events happened. However, look at participant H. The event did happen, but it happened before, to the left of the observation period. So this is left censored. Nothing happened for participant H. No event happened during the observation period. So this is left censored. Is that clear? So here, those hollowed out dots that happened within the observation period are right censored, meaning they are event free during this period. And then those that have the full dots within the observation period are not censored. This B, C, F, and J are not censored because they experienced the event. All right, is that any clearer? A bit clearer, hopefully. Informative censoring. Those are the most common examples that we encounter. Just those are the most common. Either the patient is too sick or too well, because those are factors that affect the probability of them being censored. So I can't think right now, and I can message you later on of a more concrete example. But I think we need to push on, um, unless there are other questions on censoring. Sorry. Now, this is where it gets more exciting. So we now look into estimation of survivorship. So survival data is composed of time and event. So you always think of the time component and event component. Time meaning when does an event occur? And usually we measure it from enrollment or first observation. So time since we enrolled the patient to the study, into the study. So that's how we describe it. And the event is an outcome of interest. Say for instance, we say the event of interest is death or mortality. So we name that as one. And then if the patient is censored, meaning non-informative censored in this case, it's zero. Okay, so we name it zero in this study. So I made a plot here, a data frame from a randomized control trial of new drug for treatment of stage 4 ovarian cancer. There are 46 participants, and this is the data set. So I just made this up, but so the time here is in months, meaning at 4 months, one patient died in this new drug. At 7 month observation period, one patient died. At 9 months, for 7 months, two patients died. For 9 months, one patient died and two patients dropped out. Okay, so this is what it means. So just like very, um, very loosely look at that. And you don't have to know this because we will go through it together. So in summary, in the new drug, 11 deaths occurred over the 36-month, it was a 36-month observation period, and 12 were censored. So in total, there were 23. For the old drug, those who are receiving the old treatment for ovarian cancer, 21 deaths occurred, and then two were lost to follow-up or censored. So we used 23. So you don't have to know this, but I left it here. So if anyone is interested in statistics, can look it up. But we count the following: the number of event at each time point. So Kaplan Meier is an estimate of survivorship, and we look at the number of event at each time point, and then the number in the risk set. So and we will go through that together. And lastly, the readjusted number in the risk set. So as a patient dies and falls out of that pool at risk, so your number of at risk set will be smaller. And I think it can be better shown here. Okay. Focus first on this. Remember, these are from the table I showed earlier, from this side. So every number here represents a participant. The 4, the 7, and the 9, etc., they represent the month at which the event or the censorship occurred. If the observation is censored, it has an asterisk here, as you can see. All right. So for instance, one patient died at month 4, one patient died at month 7, two patients died at month 7, one patient died at month 9, but two patients dropped off or were censored during that time, and go on. So together, let's look at this. So at time 0, at the very start of your observation, how many people were at risk? 23, because that was the baseline that were enrolled. So at month 0, 23 patients or participants were at risk. We didn't have any event then, so you don't see a 0 here. We weren't censoring anyone. That's a 0. And then we'll just put 1 for the time being here. Okay, now we go to month 4. So at month 4, there were still 23 patients or participants that were at risk, so 23. There was one event. So number 4 here represents one event. One patient died. No one was censored. There is no asterisk here for number 4. So we compute this value, ni minus di, the number at risk minus the event. So 23 minus 1, and we divide it by 23. And that comes up with 0.9565. Okay. And then we have 1 here from the row above. So 1, this is the recalculation of that. 1 times 0.9565, so it's still the same. When we go to the next observation period, which is month 7, so here, month 7, so the number of patients or participants at risk in this group is smaller now because one patient already died, right? This event. So you will subtract this 1 from this one, the number at risk. So 23 minus 1 is 22. And then during that month, how many events happened? There were two events, so 2 number 7s here. And then no participant was censored. So there were 2 events, no censored. And then this you can compute. So this will be 22 minus 2 over 22. So 20 over 22, which gives us, yeah, 0.9091. And then we multiply 0.9091 with 0.9565. Okay. And then for number 9, so at month 9, there were, so again, 22 minus 2 is 20, number at risk. There was one death, one event, and then 2 patients were censored here, as you can see with the asterisk. And then we divide, so 20 minus 1 over 20 will be 0.95. And then again, we multiply this together, and so on. So in paper, this is how it looks like if you're going to do it manually. But of course, computers are there to help us come up with this. And this is what is already seen in when you read your journal articles, when you see presentations online. This is what you will see. Okay, before we proceed, any question there? Do you guys understand what, yeah, that point? So I'll continue. So now this is what you see actually in the this is what you see during the when you're reading articles. So this is that representation, the Kaplan Meier estimate of survivorship. And we have here the new drug and the old drug. So the new is the color red and the old is the bluish one. And every drop here, so every time there is a drop in this curve, that represents an event happening. So every time there is a drop, you can see that a death has occurred. And then every time you see these kinds of small dashes, those are censored observations. So censoring happened during that time. Another thing that you will see here is that you can see 2 lines. So one representing the new drug and one representing the old drug. You can also see that there is this shaded area, and that represents the confidence interval. I'm sure you have had topics on confidence intervals, but if you want any clarification now, that just ask away. But this shaded areas represent confidence intervals. So you can see here the observation period. So we are observing for 36 months. And in this study, so it was divided into every 6 months you have a representation here. It's also worth noting that we take into consideration the number at risk. So you can see the number of people at risk as they went through the observation period, such that so for the new drug, the color red one, so most people, there are still many more people at risk at the end of observation period, meaning many more people survive because they're still being seen. Whereas for the old drug, for since they started on 24th, actually the last event was around before the 20th month. So nobody in that group was left. So they already died. And as you can see, so the old drug reached zero survival probability, meaning everyone in this group had experienced the event, plus some were censored. There were two censored observations, but they reached the event. And you can see here a p-value. We'll describe that in a while. But we can also look at median survival. And median survival is the time when there's 50% of the population of that, or the population within that group survives. And that median survival time uh, is 4 months for the old drug, and for the new drug, it's 28 months. So it's a very, very big difference in terms of median survival, meaning those who were undergoing treatment using this old drug had, 4 months median survival, whereas the others had much longer, 7 times that. Okay. So these are some of the features of the Kaplan Meier curve. And I think I summarized here. Yes. So the Kaplan Meier curve shows the distribution of survival probability over time. And again, every drop represents an event. In this case, that event is death. And censoring is accommodated. And the curve does not reach zero if not all participants experience the event. So in this case, not all patients or participants in the new drug experienced death, an event, so they did not reach zero. However, everyone in the old drug group had experienced the event, so it reached the graph, or the curve reached zero. And the good thing about Kaplan Mirror is it can allow us to show visual representation, visual comparison in between groups. This is not always easy to describe all the time. So this is an example, an academic example, just to show you how big of a difference they are. But in reality, many of the studies that we see are quite closely linked together. So the curves are quite close together, meaning, so it can be difficult to have a very, very clear visual description of it, of which one is better based on this. So it just shows you a picture, a graphical representation. So that is one limitation. And we used log rank test. So it's a test for statistical test, it's a hypothesis test to evaluate the equivalence of groups in KM estimates. So meaning, and use, it will look into, are they different? It's going to test the hypothesis that they are same. They are the same. The survival estimates between the new drug and the old drug are the same. So which is, represented here. So that's the null hypothesis. So it generates a chi-square statistic. So when you run it in a computer, I'm using R here. If you guys want to talk about me about R, that's also cool. Maybe out after this, but yeah, so it uses chi-square statistic. And then it shows us a p-value, gives us a p-value. So it's 0.0002. These are 7 decimal places. So it just means that, as you can see here, so this is a very small p-value. This is reflected by that. What does it say? It tells us that they are different, but it doesn't tell us how big of a difference how big of an estimate of a difference they have between these two groups. It just tells us that they are different, but doesn't tell us how big of a difference that is. Okay. So the limitations of Kaplan Meier, it's largely descriptive, as I've told you. It cannot be used for multivariable analysis because we're only looking at one factor at the same time. So in this case, we're just looking at the effect of treatment in the survival of these individuals. Of course, we record many other different things when we take into consideration mortality, we take into consideration many other things that may affect that mortality. But in this case, it's just the treatment. So ideally, we would be able to look into other possible contributors to death. But right now, this Kaplan-Meier estimate cannot do that. So, and you cannot take into consideration time-dependent variables. And again, log rank is only a test of significance. So we cannot provide an estimate of the size of the difference. Okay. So any questions so far with Kaplan-Meier? So we talked about survivorship and we talked about how Kaplan-Meier curves are constructed, but of course we use computers program softwares now. But do you have any questions so far before we proceed with Cox regression analysis? So in response to those limitations, so we have so in response to this limitation, so we cannot, I think primarily we cannot really provide an estimate of the size of difference, and we cannot do multivariable analysis with what Kaplan-Meier is right now. We do Cox regression, proportional hazards regression. So it's a regression model taking into consideration survival data. Remember, survival data again is composed of time and event, and it generates hazard ratio and a confidence interval, something that was not possible with the other method. Well, with Kaplan-Meier. So this kinds of analysis actually go together, and they complement each other well. So after Kaplan-Meier, we do a Cox proportional hazards regression. But there are many other methodologies, but I'm just sharing with you right now are the most commonly used ones in literature, and I think very useful and as to learn as future physicians yourselves. So it allows for multivariable analysis, and we with the hazard ratio, we know the effect size of the difference in events. So just as a review, linear regression, the form is y prime equals beta 0 plus beta 1 x. So that's just these are just the general forms. The logistic regression, same right side, but the left side looks into odds. So log of odds of an event happening. In Poisson, log of rate. In Cox proportional hazard regression, we look at hazard, so log of hazard. And hazard is rather difficult to assess actually. Hazard function is rather difficult to assess because of the variability that happens throughout the observation period, throughout how it is mathematically described is quite complicated. So this regression model takes that into consideration with a certain assumption that is central to our understanding. But before we go there, I'd like to check if anyone understands how ratios work again. So what does a hazard ratio of 1 mean? I'm not sure if I made a poll, but let me just check if I made a poll for that. Okay, it's fine. But a hazard ratio of 1 means that there is no difference in survival between groups. Okay, so there's no difference in survival between groups. A hazard ratio of more than 1 is there's a higher chance of event, or in this case, it can be mortality in the intervention group. And a hazard ratio of less than 1 is the reverse. There is lower chance of the event in the intervention group. So this is how you interpret hazard ratio, because again, the Cox regression model will come up with a hazard ratio. Okay. So this is done in the computer, and for this data set, I run it through R, the program, and it came up with this report. So what is important for you to know right now is for this study, the hazard ratio was 8.3. So relative to the new drug, the old drug, the new drug performed um, with 8 point, and I will go through the interpretation in a bit. So 8.3. So that is quite high, meaning the old drug, using the old drug contributes to 8.3 times risk of dying or hazard of dying if you're in the old group. And then it gives here a confidence interval. So between 3.3 and 20.86. So that's a very wide confidence interval. And the other thing that I want you to take into consideration is it will come up as well, aside from, so we got the estimate here, the point estimate, and then we got the confidence interval, and then we got a p-value as well, which is 0.000006. So it means it's a very small p-value, and we can reject the null hypothesis. So this is how Cox regression works, and how it's uh, computed using a software. You will normally come up, you will normally encounter um, different reports of Cox regression, and usually the hazard ratio is generated through a Cox regression method. Um, but again, it depends on the assumption that it's in the name, proportional hazard. So the ratio of hazards between an individual in one group and another individual in the other group remains proportional over time. Oh, okay. I must have deleted um, the other curves. But is there, okay, let's launch a poll here. Is there any graph here that is showing any proportional hazard assumption that satisfies the proportional hazard assumption? So these are two lines, different groups here. And is there any curve that reflect that proportional hazard assumption? So there's supposed to be a line here. Uh, sorry, it's supposed to be a line here in A and then a line in B. So again, proportional hazards assumption is that the ratio of hazards between an individual in one group and another individual in the other group remains the same. So, or remains constant over time. So which among these graphs, A, B, C, and D, do you think are proportional? So that they should be, meaning they should run parallel to each other if they're proportional. So the correct answers are A and B actually, because they, again, if even if the hazard, so this represent hazard, if you cut a slice here, it will be one hazard. They remain proportional to each other, even if they have different values of hazard. It's the same for letter B. They look like they are parallel to each other, so they remain proportional to that. For letter C and letter D, the hazards are non-proportional. We have to use different tests for this kinds of data. But many of the medical data that we have are actually have proportional hazards and satisfy the proportional hazard assumption. Yeah. So letter D does not reflect a proportional hazard assumption because, as you can see in the differences in the colors of these curves, so they have a different proportion here at the early part when you compare it to the later part. It's the same for letter C. So they have a different proportion of hazards here when you compare it here. They will somehow invert. That proportion will invert. So that's the difference between them. When compared to A, so they look quite parallel and the proportion of hazard within this time looks similar. That's also for letter B. So, and there's a way to test this mathematically and using software. So we test this using this test called plot of, okay, it looks plot of log of negative log of the survival function. But what it just tells us is that we transform this curve. So remember, these are the survival curves earlier, and we transform them. And if they are parallel, it seems that the proportional hazard assumption is maintained. So they look parallel grossly. There are other ways to test this, but it is one of the more common ways. Although you don't normally see this in journals. But you can do the backtracking and testing yourself. But again, these are part of statistical packages that you can use. So the plot of the log of the negative log of the survival function, this one over time. So that is an evaluation of this assumption. So if they perform and they look parallel, it's more likely that they are actually uh, proportional in hazards. So that's, I think, about it for the Cox proportional hazard. So again, sorry, I'll just stop this. Okay. So for the Cox proportional hazard regression, so we come up with the hazards ratio and a confidence interval and a p-value. But it doesn't generate a relative risk. So relative risk is different because it doesn't take into consideration censoring and the time element. So those are things that are evaluated with the hazard function and the survival function that we talked about at the very start of this short lecture. Any questions so far? And I have a few practice questions for you. Um, yeah, that we can go through together. But any questions so far before we go there? We have 10 plus more minutes. Okay. So if there are no questions, let's go through the quiz that I sent to you earlier, last week, and let's go through them together. Okay. So for practice question, and I'll launch a poll here. Which of the following statements best describes the hazard function, small ht? So is it the probability that an individual will survive up to and including time t? Is it the overall probability of an event occurring throughout the observation period? Is it the instantaneous rate of an event occurring at a specified time? Or is it the sum of all instantaneous rates of an event throughout the observation period? It sounds very wordy, but what do you guys think is the definition or the best description of the hazard function? Small h here. So remember, there's a difference in the hazard function and the big H, the cumulative hazard. So this is a small h. So it is important to know this because this is the foundation of Cox regression and survival analysis. One of the descriptors of varying rates of in survival analysis. So majority of you said that it's letter C, the instantaneous rate of an event. And you're correct. So this is the instantaneous rate of an event occurring at a specified time t. It's different from the cumulative hazard. The cumulative hazard here is letter D, the sum of all instantaneous rates of an event. So this is cumulative hazard. And letter A is the survival function, the probability of an individual will survive up to and including time t. So D is if it's a probability, it can be one of either risk, relative risk, or odds, depending on the statistic that is used. But so again, letter A is survival function. Letter B is either risk or odds. And letter C, depending on the, but here I think it's a risk, relative risk. Letter C is the hazard function. Sorry, hazard function small ht, and letter D is the cumulative hazard function, the big ht. All right. Next question. So for this question, so the following statements are true regarding censoring, um, except A. Censored participants refer to those who did not experience the event during the study period. B. Right censored participants refer to those who remain event-free until the last period. So except meaning which is the wrong statement. Letter C, informative censoring, in which the probability of being censored is related to the probability of the event, applies to participants who are deemed too ill to attend follow-up and assessments. And letter D, Kaplan Meier estimates, Cox regression, and log rank test assume that censoring is informative. So yes, so it's a question on censoring. The following statements are true except, so whichever is the false. We're looking for the false statement here. Okay, I'll end the poll. So half of those who answered said that it's letter D. That D is not true, and the correct answer is D, because remember that this should be non-informative censoring. So the assumption is that censoring here is non-informative, meaning the probability of being censored does not relate to the probability of the event. So the example again of non-informative censoring is finishing the follow-up period, completing the study period without experiencing the event. So A is correct. Censored participants refer to those who did not experience the event during the study period. B is also correct. Right censored participants are those who remain event-free until the last observation time, meaning they finish the study time and they haven't experienced the event. And letter C is true. That's the definition of informative censoring. So in other than those who are too ill to attend follow-up, those who are too well and they decided to drop out and travel elsewhere or like move elsewhere is also an example. Those are the common ones. All right. Now, question number 3. So the following statements are true regarding Kaplan Meier curves except, so here we go again. So whichever of the statements is false essentially. So 1, letter A, covariates can be controlled using Kaplan Meier curves. Covariates meaning other variables can be controlled, can be studied. Letter B, the log rank test is used to evaluate statistical equivalence between two or more curves. Letter C, Kaplan Meier curves, event times are represented by the drops. So remember the drops that we see, what do those represent in the Kaplan Meier curve? Are they events? And then letter D, if at the end of the observation period, not all participants experienced the event, meaning not all died, the curve should not reach 0. Okay, let's end the poll. So 75% of those who responded said that it's letter A. Covariates can be controlled using Kaplan Meier curves. And that is correct. Congrats. So covariates or other variables cannot be controlled using a Kaplan Meier curves. That's why we do, because you only have one factor being represented at any point in time. That's why we do Cox regression. So that gives us additional option in doing multivariable analysis. And let's go to question number, and the rest are true. So these are the definitions of Lagrange test, as I said in the previous part of this lecture. Okay, so this is in the quiz, but what I just want you to see is, so in this graph, so in this Kaplan Meier curve, so it just shows the effect of, I think it's erlotinib on, which is a drug, a tyrosine kinase inhibitor, on mortality among patients with lung cancer. So the erlotinib group is the blue one in this case, and the placebo is the red one. But what I just want you to focus on here is the hazard ratio here. So hazard ratio of 0.71 and the confidence interval, so they did Cox regression here, is 0.62 to 0.82, and the p-value is 0.001. So let's look at the relevant question. So which of the following is true regarding the study results? So take into consideration again, the hazard ratio is 0.71. And then it looks statistically significant, and the confidence interval does not cross 1. So let's look at the choices. So on average, participants receiving erlotinib had 71% lower risk. Letter B, 29% lower risk. Letter C, 71% higher risk. And letter D, 29% higher risk. So what do we think? Based on the based on the curve, the Kaplan Meier curve earlier that I showed. So with a hazard ratio of 0.71, this is the curve. So 0.71, the hazard ratio is 0.71 here. So what is our interpretation of this curve? So is it, so letter A is the risk of dying is 71% higher. Letter B is the risk, oh, sorry, lower. And then letter B is 29% lower. Letter C is 71% higher. And letter D is 29% higher. I think I'll stop just in the interest of time. And so in the poll, majority said it's letter B, which is the correct answer here. So letter B is the correct answer because, so remember, this is a ratio, so a hazard ratio. So the way you interpret this is you you subtract this 0.71 from 1, which or 100%. So 1 minus 0.71, and that will be 29. So it will be lower, 29%. The risk of dying when you are in the erlotinib group is 29% lower compared to when you're in the placebo group. So yeah, that's how you interpret this. Okay. So on average. Okay. And then, lastly, so the following statements are true regarding Cox regression model and hazards ratios, except A, it is a regression analysis of survival data that incorporates time-dependent variables. Letter B, it assumes that the ratio of hazards between group remains constant over time. Letter C, aside from hazard ratio, the Cox regression model also generates relative risk. And letter D, plotting the graph of log of the negative log transform survival function is used to examine the proportional hazards assumption. I'm gonna share this. Yeah. So again, which of the following is false uh, in this list? Remember what the Cox regression generates? It generates hazard ratio, it generates confidence interval, it generates p-value. Does it generate relative risk? And does plotting the log of the negative log transformed generate or is used to examine proportional hazards? So about half of you said that it's letter C, and which is aside from, so the false statement here is that aside from hazard ratio, cost regression also generate relative risk. So again, this is the correct answer. Um, the Cox regression does not generate relative risk because again, relative risks, they do not incorporate censoring and the time element into its estimates. So they are very different. Hazards, although you, since they are ratios, you interpret it similarly, but hazard ratio and relative risk or risk ratio have very different properties and they're used in different ways. So Cox regression does not generate relative risk. It generates hazard ratio and confidence interval and p-value. Um, just I understand that we are over time a bit, but this is just an example of the last problem that I want. If you'd allow us to go through, um, would be
Yeah,
great.
no, we can keep going.
Yeah, just this last practice problem, and I'm free to for you guys to contact after this if you want to talk more about this. But this is just an example. So an RCT was conducted in the Philippines to compare the efficacy of new drug regimen, drug Y, against the standard of care, drug Z, in adults with newly diagnosed multi-drug resistant TB, tuberculosis. So they were followed up for 90 days. The observation period was 90 days. And the primary endpoint was treatment failure at the end. So after 90 days, if the patients had treatment failure, that was the outcome of interest. So there were 93 participants in each arm, and by the end of the follow-up, 2 patients per arm were lost to follow-up. So these were censored. So they were censoring 2 each. So it doesn't seem to be that big and that significant to affect the results. But Cox regression was done to generate adjusted hazards ratio. So far in the examples that I have given, the Cox regression results were using single variable. So this one is an example of a multi-variable analysis. So looking at here, in this case, there are 3 variables. So in the analysis, so first is the baseline time to positive growth. So positive growth of the tubercles. For every 5-day increase, so there's a baseline time, and then the baseline age of the participants. So for every increase in age, and lastly the treatment. So the reference range is drug Z. So we're looking at the effect of drug Y over drug Z. So drug Y is the new drug. So I'd normally ask you to interpret this, but due to time constraints, I'm gonna help you guide. I'm gonna guide you through this. So again, Cox regression, what it generates again, hazards ratio, confidence interval, and p-value. Okay, so the hazard ratio, let's start with the baseline time to positive growth. So the hazard ratio here is 0.81. So meaning for every 5-day increase in the time to positive growth, if there is more time to positive growth, meaning there is less of the tubercle in that sample, in that sputum specimen. So for every 5-day increase in that, it's associated with 19% reduction in treatment failure. So if there is less of, which makes sense, right? So if there is less of the tubercle within that specimen, there is less chance. In this case, there is less risk for developing, or less hazard for developing treatment failure. And the confidence interval for hazards ratio, it shouldn't cross 1, because when it crosses 1, it crosses the line of unity, and it just means that it might be statistically not significant. But in this case, it doesn't cross 1, so the confidence interval is from 0.73 to 0.86. So this is all less than 1. And the p-value is 0.02, which is usually less than 0.05. So this is statistically significant. These are adjusted for the other variables. So that's also similar for age. But in this case, it crossed 1. And you can see the p-value is not less than 0.05. So age is not, in this case, baseline age for every yearly increase is not statistically significantly associated with the outcome, which is primary treatment failure at the end of the observation period, even if the adjusted hazard ratio is 0.94. And last, so the drugs Y had very high hazard ratio. So in this case, it's 6.17, meaning those who received the new drug regimen actually experience 6.17 times likelihood of developing the treatment failure. So so this drug um, seems hazardous in a sense, and I will, if given this results, I will not I will choose not to give drug Y, the new drug regimen, because it seems that it has failed. It's contributing to treatment failure. So I would stick to drug Z and also look into other reasons why this has occurred. So you can see here for the drug Y, the confidence interval is also wide, but they do not cross 1. So, and the p-value is very small, so it's statistically significant.
Thank you so much, Grego.
Sure. Bye bye.